Okay, so today I'll be giving a talk about seizures and epilepsy with a focus on status epilepticus. I'm Saad, and I'm final year medical student at Kuwait University. So this is me. I'm already mentioned that I'm a final year medical student. I got my bachelor's degree in sciences in 2021, being in the top fifth percentile, and I'm currently pursuing my MD degree, and I'll be graduating in 2024. So outside of medicine, I do like to hike a lot. I've been through a couple of hikes and I've been to a couple of marathons. Nothing excessive, just a couple of 10 kilometers, but I am working on getting my 21 kilometers done. And so just before I give my presentation, I have no financial interest or relationships to disclose. So I'll be going over the history, definitions, and epidemiology of seizures. We'll try to classify and type them out and go over some treatment modalities and finally end it with some status epilepticus. So the history of seizures. So it was first documented in 2000 BC by the ancient Mesopotamian eras. And at the time, they used to believe that seizures were awful or by possession, and they really didn't know what was going on. Lots of people just started fainting and kind of going through a tonic-clonic at that time, and no one really knew what was going on. Ancient Greeks and ancient Romans tried to perform what was known as brain surgery at the time. They believed that the brain was actually the cause of all types of seizures and epilepsies, and they thought that removing certain portions of the brain would help cure or treat the person. And then we go on to the Renaissance era, where people with epilepsy were actually idolized and they were thought of to be as prophets. They were actually mentioned that they could see the past, present, and future during their unconscious period. So that's pretty much how epilepsy evolved into what it is today. One famous author, the author of Crime and Punishment, Mr. Dostoevsky, was actually believed to have epilepsy, given that many of his books and statements revolved around the topic. And so what is seizures? What are seizures? So normal brain activity is dysynchronized. It is not flow. The electricity in the brain does not flow all in the same direction. During a seizure activity, this electrical activity all flows toward the same direction within the same time and space, and that gives rise to the clinical manifestations of seizures. So let's start off with some definitions. So a seizure is a temporary alteration in brain function due to excessive or synchronized neuronal activity. And many people kind of complicate this with epilepsy. They are two different entities. Epilepsy is a group of disorders characterized by a tendency towards recurrent, unprovoked seizures. So they're kind of used as synonymously in some literature. However, the proper physician knows how to distinguish both of them. Epilepsy is like the condition to meet epilepsy is more than two unprovoked seizures or more than one unprovoked seizure with a high probability of seizure recurrence. So some statistics, 75% of people with epilepsy live in low-income countries. And 70% of people with epilepsy could be seizure-free if properly diagnosed and treated by a neurologist. And 25% of epilepsy cases are potentially preventable. So some stats about the US. As you guys can see, the hotspots for seizures and epilepsy are all colored in dark blue, and the lighter green shades are where it's less frequent. And so the top three leading states for seizure recurrence is California, Texas, and Florida. And it's actually rated the fourth most common neurological condition in the States, the first being migraines, the second being strokes, and the third being Alzheimer's disease. And so the single most common cause of seizure occurrence is non-compliance to medication. And that's kind of a caveat to remember. So what are the types of seizures? There's 8 main types of seizures in today's literature. Of course, new publications are coming out every day, and new case reports demonstrate different types of seizures, but they all kind of revolve around these 8. And we'll be going over all of them. So we'll start off strong. So focal seizures, the name kind of gives it away. So focal seizures are limited to one hemisphere of the brain. and it's subdivided into two parts: focal without impairment in consciousness and focal with impairment in consciousness. So now the older generation might have a different naming, and that's simple partial and complex partial, but due to the controversy of naming a condition such as epilepsy or seizures with simple and complex, it kind of demoralizes the condition, and so the new naming strata was implemented. So without impairment in consciousness means they're just having the seizure. They might be aware during the episode. They won't fall down unconscious. And it's usually associated with positive symptoms. That could be motor, it could be sensory, such as somatosensory, or it could be psychic, such as deja vu, hallucinations, be it olfactory or audiovisual. And focal with impairment in consciousness, previously known as complex partial, is typically associated with automatisms. So that could be lip smacking, chewing, or even picking at the buttons of their clothes. Next off, we have the generalized seizures, which involve both hemispheres of the brain, subdivided into primary and secondary. So how does a primary seizure occur? Typically starts off in a part of the brain that's well connected to both hemispheres. And the single most important place is the thalamus. It's connected to almost every single portion of the brain, and it would be just the right place for a primary generalized seizure to start. A secondary generalized seizure would have preceded a focal seizure. However, the focal seizure may or may not be clinically evident. For example, if someone had some lip smacking, maybe some pill rolling seizure, that might not seek medical attention, and he could eventually develop into a secondary generalized seizure if it spreads onto a well-connected portion of the brain. And then we have these three: the myoclonic, clonic, and tonic. So the myoclonic is rapid involuntary muscle contractions, the clonic is the rhythmic jerking, and they're typically differentiated clinically and electrographically. So the myoclonic seizures are shorter, more of in a pattern, could last from milliseconds to seconds. However, the clonic seizures typically last a little longer, and they're more whole body generalized. Tonic seizures are sudden, strong, sustained muscle stiffness, and so that's why when someone typically goes through a tonic-clonic, we ask them if they have some lip biting, because during the tonic phase, or even during the clonic phase, it can seriously injure their tongue. And so this just demonstrates how a typical tonic-clonic would look like, tonic being that sustained muscle rigidity, stiffness throughout the whole body. They can have this extensor positioning, and the clonic phase, which is that rhythmic jerking. And then last but not least, we have absence seizures, typically divided into typical and atypical. And the sort of caveat for absence seizures is the 3 Hz spikes, episodes of unresponsiveness and eye fluttering. However, the atypical one will have different EEG manifestations, more automatisms, and could last longer than an absence seizure. And so how a typical absence seizure would present is the teacher or the primary caretaker of the child saying that, my kid just kind of dreams away during the day, or is not scoring as high as he should be during his exams. And so after like a video recording or a visit to the neurologist, he'd be properly diagnosed with absence seizures. And now to my favorite part, status epilepticus. So 2 main definitions for status epilepticus. There's the operational definition, which is what we use in neurocritical care, what we use in the hospital during rounds, and that's more than 5 minutes of continuous seizures. Once the patient has more than 5 minutes of continuous seizures, we can technically diagnose him with status epilepticus without any history or knowledge of his background. So anyone seizing for more than 5 minutes can be diagnosed with a status epilepticus. Or more than 2 discrete seizures with an incomplete recovery period between both of them. And now the International League Against Epilepsy has a more organized definition, and that's what you guys typically see during literature reviews or during case reports, and it's just to make everything more organized. They define status epilepticus under 2 main standpoints, which is T1 and T2. T1 being the time period where the patient is going through a prolonged seizure that's unlikely to stop, and treatment may or have may not failed to abort the seizure. T2 is a period after the status where the patient's a bit drowsy, and we can kind of de-alienate all the complications that may or may not happen. And so the most common cause of status epilepticus is metabolic abnormalities, anti-seizure medication non-adherence, and acute structural brain injury due to trauma. And so is there an autoimmune cause related to status epilepticus? The answer may be yes. There is a cause called autoimmune encephalitis, which some literature reviews have demonstrated to be linked to paraneoplastic etiology. It is a more refractory compared to other causes of status, and it actually may respond favorably to immunosuppressive therapy. And so you guys can see on the right-hand side a list of antibodies that have neurological complications, many of which could lead to seizure activity and eventually status epilepticus. So we've been through the type of seizures, the general seizures, and now we'll be going through the type of status epilepticus seizures, which have some minor changes. So there's the generalized convulsive status epilepticus, focal motor status epilepticus, myoclonic SE, and tonic SE. So GCSE, or generalized convulsive status epilepticus, is the most dramatic form, has a serious potential complications, morbidity, and mortality. And that's sort of the tonic-clonic that we were talking about a little while ago, but now it's been going on for more than 5 minutes. Then we have FMSE, which is focal motor status epilepticus, which has many, many clinical manifestations, largely depending on where in the brain the seizure activity is happening. And almost all of them are associated with these four: heterotropias, which is basically normal neurons in the wrong place in the brain. It could be a vascular lesion or an infectious lesion. And lastly, a tumor. So epilepsia partialis continua, which is a subset of FMSE, is a very prolonged and very regular jerking seizure with a retained awareness. And the most common condition to cause this is Rasmussen's encephalitis. And it's de-alienated with the right-hand side brain MRI. And we have MSE, which is myoclonic status epilepticus. So that's frequent generalized myoclonic jerks. There's many, many forms of MSE, and they typically arise in syndromes of genetic epilepsy. And last but not least, we have TSE, which is tonic status epilepticus. It's very common in Lennox-Gastaut syndrome, difficult to abort with medications, and benzodiazepines may actually exacerbate seizure activity. So, how do we diagnose status epilepticus? And the single most important answer is clinically. So the physician is the center point of diagnosis and treatment. You do not require any background or any history to diagnose a status epilepticus right off the bat. History would be supportive, and obviously there are many tools that we can use, but status epilepticus is definitely one of those conditions where someone straight off the ER or an emergency medical provider can actually help manage. And so how do we abort a GCSE? So how do we treat it? So there is this huge paradigm, like stepwise process that physicians have created. And although it goes under many reviews, this is what the most efficient way to abort a seizure. And I'll be simplifying it over the next couple of slides. So the most important thing you want to do is airway breathing circulation. Make sure that the patient's patent airway and that he can breathe. Make sure that he's not bleeding out, that he's in a safe condition, and airway breathing circulation, always. That's the first and most important step towards any emergency medical problem. Next off, we have to connect two IV lines, one on the left and one on the right. Benzodiazepine, typically lorazepam, is started, and on the right we'll have an anti-seizure medication. The most common is Keppra, but other medications such as phenytoin can also be used. Then we reassess the patient. Has his seizure aborted? Is he still seizing? How's he doing clinically? Has this been going on before he came? When was he last known to be well? And then we can reassess him within 5 to 10 minutes. If he's still seizing, we'd give him another dose of benzodiazepine, typically lorazepam again. And then we can wait 10 more minutes And by now, a neurologist would have to be on board because they're well trained to abort status epi. And we can give the patient another 15 to 30 minutes, and by then we'd have to interfere again. An ICU bed would have to be prepared. We'd have to prepare for a rapid sequence intubation, so anesthesia also has to be on board, and another dose of anti-seizure medication can be started, and preferably a different one than that was used in the past. 30 more minutes, and now we'd have to get the patient an ICU bed with continuous EEG monitoring. He'd have to be intubated to protect his airways, and midazolam infusion would have to be started. And so I'd just like to share that I actually got seizure recognition and first aid certified yesterday by the Epilepsy Foundation. And I'm glad that I got that done. I feel like I'm very confident towards aborting a status epi, and I'd like to help many physicians to do the same. And so these are my references, most of which are from UpToDate. And I'd like to thank you for attending my presentation. Do I have any questions?